Friends, cataract surgery has become a refractive surgery. And we want to hit the bullseye each and every time we operate. And we are rather pretty successful in doing that. For example, uh, Savini et al. In a very recent publication showed that all the recent formulas, the current formulas, they were able to land up within a prediction error of plus minus 0.5 diopters from 88% to 90.67% of the eyes. So this is a phenomenal number. So we would like to hit the holy grail, get plano 66 in all occasion patients, and how do we go about it? I'm going to share with you my strategy. There has to be a paradigm shift, and we should not view IL power calculation is just a small activity to be ticked off for all our cataract patients. It basically transcends the preoperative, intraoperative, and postoperative period. Preoperatively, I would like to seek certain additional information about the patient's cataract. Is it a very dense cataract? Does the patient have a good fixation? Does the patient have staphyloma? Does the patient have amblyopias? These are the information that are going to help me a great deal. I'd also look at the ocular surface, because over the last couple of years, we have known that it has a very significant bearing on the IL power calculation, not only for the toric IOLs, also for the intraocular, for the monofocal intraocular lenses and the multifocal lenses. And another point that I would like to highlight here is what is the desirable pupillary status? Should we dilate the pupil before performing biometry? I would say no, because when a patient undergoes a workup, even if you do non-invasive techniques, you dilate the eye, it's no longer a virgin cornea. You might have done applanation torometry, gonioscopy, etc. So I would like to call the patient back on another day to have a virgin cornea for the biometric workup. And I would not, for the same reason, I would not like the pupil to be dilated, because some studies have shown that the pharmacological dilatation results in an increase in anterior chamber depth, and this concept has been around for about a decade or so. This particular study, published in Ophthalmal Therapy, showed that after dilatation, the anterior chamber depth shows a significant increase, and that has clinical bearing. See, for example, post-dilatation measurements with the Barrett, Olsen, Hill, RBF, and Hygie's formula overestimated the IL power by 0.5 or 1 diopter in a significant chunk of the patients. So a cataract surgery patient should receive biometric testing in an undilated state. We also have thought about using artificial tears. This is, I think, quite a common practice just before biometry. It should not be done. And if you have put an artificial tear drops in the patient's eye, please wait for at least 5 minutes for you to perform the biometry. I use multiple devices to get my biometric parameters, particularly for toric IOLs. And if a patient is using contact lens, it has to be removed a couple of days prior to keratometry. And for a hard contact lens, 2 weeks prior to keratometry. Just because we are using an optical biometer does not mean that things will become fine, regardless of whatever we do. The values have to be validated. There are validation guidelines available, and please make sure that you validate your biometric results that you get. And if you don't get a good result, a suspicious result, delete it and remeasure it. Go into the habit of using the more modern formulas. They have been doing much better over the years. And last couple of years, I think the Kane formula has done extremely well for the standard non-toric IOLs, as well as keratoclinic patients. I always believe in using multiple formulas. For example, this is a post-ICL cataract, and I had used SRKT, Holiday, 1, Hygie's, Hoffer Q, and adjusted the axial length using the Vancroft modification factor. And these formulas suggested an IL power of 3 diopters. On the other hand, Barrett Universal 2, which is my go-to formula, suggested an IL power of 2 diopters. Ultimately, I used a 3 diopter IOL. So I think for odd situations, it is better to use multiple formulas and arrive at a correct decision. Patient counseling as regards refractive targeting, etc., is important. And after all these issues are considered, the intraocular lens has to be selected in a proper manner. Now, for dense cataracts, optical biometers may not give you appropriate results. I'm not talking about the swept source OCTs based biometers. So I have a very useful and efficient strategy to counter these cases. not for bilateral mature cataracts, but for unilateral cataracts with a fellow eye being pseudophakic or having early cataract. So my trained optometrist performs optical biometry as well as ultrasonic biometry in this eye, in the fellow eye. And if there is close agreement between these two values, then I can reasonably assume that the technique, the biometric technique has been properly employed, and the value that I get for the fellow eye for ultrasound biometry may be relied upon. So this test is repeated once again for confirmation. Use a proper lens constant for optical biometer or ultrasound biometry. Intraoperatively, please make sure that you implant the lens within the capsular bag with an overlap of a 0.5 to 1 millimeter of the rexis on the optic. And post-operatively is the moment of truth. Here you realize how you have been performing and whether you need to make changes the way you you perform biometric workup of your patients. Lens constants used to be very important once upon a time, but with these formulas, with the lenses available from the multinational companies, I tend to go with the lens constants which are already there in these online calculators. However, with the new intraocular lenses, for which we have no known value of lens constant, so I use the manufacturer's lens constant and be ready to modify it, by modify the lens constant depending upon the results that we get. Again, we have come a long way in terms of our biometric performance. We are getting very accurate K reading. We are getting very accurate axial length, etc., etc. But the industry has not kept pace with time. Most of the companies still provide us lenses in an increment of 0.5 diopter steps. And though a few companies have come up with an increment of 0.25 diopter, and the various companies like ISO allows some degree of tolerance for these lenses. And none of the companies really put up the exact power of the lens on the lens box. And the companies also do not reveal, they do not disclose what exactly is the tolerance that they use in their own company. So if I give you an example, now if we have if your formula has calculated a lens power of 21.31 diopter for emmetropia, then we are going to go for 21.5. Now, if you see here, if for a 21.5 diopter intraocular lens, the permitted tolerance is 0.4. So you could also be ending up using a 21.9 diopter intraocular lens, which means you have a refractive mismatch of about 0.59 diopters. I also believe in using the first eye prediction error in cataract surgery to refine the refractive outcome of the second eye. There has been a lot of literature over the last 15 or 20 years on that. And these are the conditions that have to be met for you to use the fellow eye as your refractive, as your guide to calculate the power for the eye to be operated. So the first eye, the prediction error should be more than 0.5 diopter. Both the eye should have ocular symmetry, similar axial length and K reading. Transcription errors and IL malposition errors should be excluded. And for the bad eye universal 2, regression analysis studies have shown that you require an adjustment coefficient of 0.3. And for the standard older generation lenses, Hoffer Q or Holiday 1 and SRK2, it is the coefficient is 0.5. So for example, in the fellow eye, if you have landed up with a refraction of +2 diopter in the postoperative period, and when you're operating on the current eye, we don't adjust for the +2 diopter. Rather, we will take this coefficient factor +1 diopter, and I will, which means, and I will aim for a -1 diopter for this eye to be operated for a plano target eventually. So this has definitely helped me in situations where there has been small amount of refractive surprise, provided these criteria have been met. There are new formulas like Pearl DGHS formula that take this, that has been taking the second eye factor into account. There is an emerging concept that gender also influences the different types of formulas. For example, the bad eye universal 2 has a lower mean absolute error for the males compared to the females. So friends, in conclusion, I'd like to say that use validated measurements, work with properly optimized lens constants, adapt to new technologies as they present, employ the right formula, and strive to use all available resources to the best advantage. Thank you very much for your kind attention.